Good morning. This is Nasser Amash. I'm one of the adult congenital heart disease specialists at the Mayo Clinic in Rochester, Minnesota. I'm going to talk to you today about Eisenmenger syndrome. Eisenmenger syndrome is one of the complex congenital heart disease noted in adults. The most common underlying cause is an intracardiac shunt in the form of a ventricular septal defect. In these patients, in early life, into childhood, even some into adulthood, it's a left to right shunt occurring at the ventricular level. That creates more pulmonary blood flow over time. That increase in pulmonary blood flow would lead to first reversible and then irreversible change in pulmonary vasculature that will lead to pulmonary hypertension if the VSD is not closed at the appropriate time. These pulmonary vascular obstructive changes will lead to severe pulmonary hypertension, where the pulmonary arterial pressure equal or become more than systemic blood pressure. And as a result, the right ventricular pressure increased significantly, even higher than the left ventricular pressure, causing a right to left shunt or a reversal of the shunt with associated cyanosis. So in order for you to have Eisenmenger syndrome, you have to have a triad of a ventricular septal defect or atrial defect or an intracardiac shunt that's unrepaired. You have to develop severe irreversible pulmonary vascular obstructive disease, and they have reversal of the shunt with cyanosis. Although VSD is the most common cause of Eisenmenger syndrome can be caused by other shunts such as PDA, AV canal, and atrial septal defect, and is also noted in some more complex congenital heart disease such as a single ventricle without pulmonary stenosis, pulmonary atriosus, truncus arteriosus, and aorta to pulmonary shunt that at times are surgically inserted. When we talk about Eisenmenger syndrome, we talk about a multisystem disorder in which many organs are involved, and it's not only the heart. The most important abnormality in Eisenmenger syndrome is the physiological adaptation to cyanosis. With cyanosis, there is increased erythropoietin secretion, causing the hemoglobin to go up as a form of compensation. So it's a compensatory mechanism with which you see secondary erythrocytosis with a hemoglobin between 18 and 20 grams per deciliter. This is again a secondary erythrocytosis and not polycythemia. And it's very important to have that kind of a hemoglobin between 18, 20, 21 grams per deciliter to maintain tissue oxygenation and normal organ function. Unfortunately, secondary erythrocytosis is linked to hyperviscosity, where patients complain of headache, unable to concentrate, fatigue. You can see injected eyes, and is often relieved by phlebotomy. But unfortunately, we know that repeated phlebotomy is dangerous and should be avoided. It has been very well documented that repeated phlebotomies in this setting cause iron deficiency anemia with significant increased risk of stroke, exercise intolerance, and then you go into this vicious cycle where you do phlebotomy, they feel good, then the hemoglobin go up again, then you do another phlebotomy, then it takes a while for the hemoglobin to catch up, you give them iron because they're anemic, and then it's a vicious circle that you need to break. In our adult population, we rarely perform phlebotomy, but when we do it very cautiously in a selected group of patients, and we replace them with normal saline for the same amount of cc's. One of the important aspects of management of these patients, identification and treatment of iron deficiency whenever noted. So checking MCV or ferritin is very, very important in these patients, especially those who have heavy menses or they're bleeding for other causes. And we know that judicious short-term treatment with iron, like for a few weeks only of like Vitron C or iron supplements, will be important in some of these patients, but not everybody. At the same time, in addition to the patient having increased risk of thrombosis, they also have some problems with bleeding because they have deficiency in vitamin K dependent clotting factors, they have platelet dysfunction, they have abnormalities with the von Willebrand factors. So these patients often come in with some minor bleed such as gingival bleeding or epistaxis, or major bleed such as hemoptysis. Hemoptysis is noted in up to 1/3 of the patient, and it increases with age. We used to think about it as a predictor of death, but nowadays we believe it's not the case. It's an uncommon cause of death at this time. So whenever you see a patient with Eisenmenger syndrome coming to the hospital with sputum that has blood in it, or just telling you I'm coughing blood, these are the things you have to look for: infection, in situ thrombosis in the pulmonary arteries that can happen, pulmonary embolism, bleeding diastasis, ruptured collateral bronchial artery, which is part of the mechanism by which the pulmonary vascular compensate in patients with severe pulmonary hypertension, a ruptured pulmonary arteriole, which is also a common findings, as well as pulmonary artery dissection, as you can see in this CT scan. This is the MPA, RPA, and LPA, and you can notice the severely dilated pulmonary arteries with a dissection. Fortunately, this doesn't happen. So when patients come in with hemoptysis, that's what we recommend. Imaging of the chest to make sure there's no infection, and look at the degree of hemorrhage. The patient can often tell you which lung they're bleeding from because they can feel it. I usually ask for blood and sputum culture to make sure there's no infection. We would stop every medication that could cause bleeding. We do not do bronchoscopy, but if it is significant bleeding or hemorrhage, we do take the patient to the interventional suite and potential embolization of the bleeding pulmonary artery branch. Otherwise, it's all conservative measure with hydration, oxygen supplementation, a bit of anxiolytic medication because these patients are really anxious when they see blood coming out. And of course, you can consider FFP or platelet transfusion in some selected patients. Renal dysfunction is not uncommon in patients with Eisenmenger syndrome. We know they have congested glomeruli with segmental sclerosis. So they often come in with an elevated creatinine or microscopic hematuria or some degree of proteinuria that is usually not severe, and they often have CAS in urinalysis. These patients present a challenge because often if you do a cardiac catheterization and give them contrast, or you do a CT scan and give them contrast, you have to be aware of the renal dysfunction, even if the creatinine might be normal. So you have to really hydrate very well before and after giving any contrast agent. And as part of the long-term management, you should talk to them about the danger of taking non-steroidal anti-inflammatory agents or any nephrotoxic medications. Given the fact that these patients often have a high uric acid with their high hemoglobin, and at the same time, because of the decreased renal clearance, because of the renal dysfunction, these patients have a higher incidence of gout. And the treatment of gout is the same like in anybody else. However, we don't give them non-steroidal agents. So we give them colchicine and or prednisone, and we avoid anything that could elevate uric acid. So we might sometimes have to adjust the diuretics and talk to the patient about dietary changes. And that should be always kept in mind. For the similar reasons, with increase in red blood cell mass, you have a higher level of unconjugated bilirubin that can cause calcium bilirubinate gallstones. So these patients come in with abdominal pain like anybody else with gallstones. And sometimes they're found incidentally on imaging, and we leave them alone. We can ask them to adjust the diet, but if they have symptoms, then we have to do surgery, and this is where it's important to manage them perioperatively. I would say this is one of the most common non-cardiac surgery in patients with Eisenmenger syndrome. What about musculoskeletal complaints? Well, because of the cyanosis, there's hypertrophic osteoarthropathy and scoliosis that happens more often in these patients. And we have to deal with it. One of the most complex patients I have seen is somebody who had really severe scoliosis and wanted to have surgery for it. Often, this issue is more mild to moderate in severity, causing arthralgias and some bony pains and you can see some changes on X-ray with periostosis or abnormality on the bone scans where it lights up in the different areas. And again, here you want to avoid non-steroidal as much as you can, and there are options with the biphosphonate as well as the octreotide. This is a common complaint, but usually it's mild to moderate and not severe. As I have demonstrated over the past few minutes, Eisenmenger syndrome is a multisystem disorder in which the heart is only part of it. Patients do have atrial arrhythmia on Holter monitors. They can have ventricular arrhythmia. They can have heart failure that you have to treat conservatively. And there's no proven benefit of beta blockers and ACE and ARB. And in fact, they can be very dangerous, and I would not suggest you use them without consulting with an adult congenital heart disease specialist. Sudden cardiac death is the most common mode of death in patients with Eisenmenger syndrome. It can be caused by ventricular arrhythmia, and the cause of the arrhythmia could be one of few. We have had left main compression seen in patients with dilated hypertensive pulmonary artery that we have stented before. These patients can have atherosclerotic heart disease because they live into their 60s and they might have diabetes and hypertension and other risk factors for acquired heart disease. Or they can have ventricular arrhythmia from right ventricular hypertrophy related to the pulmonary hypertension. But there are also other non-cardiac cause of sudden death that you should be aware of. Pulmonary artery embolization, rupture and thrombosis, or a dissection, or an intracranial hemorrhage due to anticoagulation or paradoxical embolism. Finally, hot showers, drugs that reduce the blood pressure, and dehydration, or a combination of those two or three, can cause sudden death. The second most common cause of death in these patients is heart failure, followed by periprocedural around non-cardiac surgery, cerebral abscesses, infection, and less so hemoptysis or pregnancy. Pregnancy is contraindicated in patients with Eisenmenger syndrome, where the maternal mortality can be up to 50%. We know that patients with Eisenmenger syndrome, when compared to patients with primary pulmonary hypertension, they do better. It could be because they have a small intracardiac shunt that improves the stroke volume on the left side of the heart and maintains cardiac output better than those who did not have a shunt, like in patients with primary pulmonary hypertension, however, at the expense of worse cyanosis. Also, these patients appear to adapt better to pulmonary hypertension, so the right ventricle gets thicker, the function is preserved until really, really later in the disease. If you take patients with Eisenmenger syndrome on no therapy, the mean age of death is reported around 37 years, but there is individual variability. And over the past 10 years or so, there is treatment with pulmonary hypertension targeted therapy, and you can name it. All of the treatment agents work. We have a lot more data with both Santan and sildenafil, but pulmonary hypertension targeted therapy would work. And they work predominantly in improving 6-minute walk and oxygen saturation, as demonstrated in this study of 210 patients with Eisenmenger syndrome. So you can see the 6-minute walk improved from an average of 297 to 325, and the oxygen saturation did improve. And we know when you give this treatment to patients with Eisenmenger syndrome, they do better. And in this paper from 2013, 153 patients were treated with 1 or 2 agents. The vast majority had simple congenital heart defects such as VSD, ASD, and PDA. And we can see that the use of the pulmonary hypertension targeted therapy improved 5-year survival from 60 to 83%. Again, this is observational data, not randomized clinical trial. So when you talk about management of Eisenmenger syndrome in general, that's what we suggest for you to do. You have to see those patients either annual or biannually. We usually check on examination in addition to their vital signs, we check their pulse oximetry, because the resting pulse oximetry is a prognostic marker. Less than 85% O2 saturation is not that great. As part of the testing, we always check for ferritin, uric acid, and renal function. We always go through the medication, make sure they're not taking anything that will harm them. Practically, our management is a do no harm approach. If they have secondary complications that we talked about, we deal with them at that time. I often do a 6-minute walk when I see this patient, because this is an objective measure of how they do. We do an echocardiogram every 6 to 12 months to look at the ventricular function and see are there any findings that will change our management plan, such as institution of diuretics. And we don't do characterization unless we meet one of those following criteria: confirm the diagnosis and look for potential reversibility for the pulmonary hypertension, especially if we consider pulmonary hypertension targeted therapy in patients with, for example, atrial septal defect, and reassess the pulmonary artery pressure after treatment to see if we are going to select them for surgery or not. And at times, we do limited right heart catheterization if we're going to escalate therapy from like 2 pulmonary hypertension targeted agent to 3, for example. There's a lot of patient education as part of our management. So this is what we tell our patient with Eisenmenger syndrome. Because of your propensity for heart failure, you should avoid salt. Definitely you don't want to smoke, and you want to avoid high altitude, because this is because of the oxygen saturation. Avoid inappropriate phlebotomies to prevent iron deficiency anemia. Maintain very good fluid hydration, especially during traveling, and avoid dehydration. And again, you don't want to take a vasodilator and go into the sauna or in a hot tub. And that includes excessive alcohol use. Avoid pregnancy. Also, we tell them typically you should avoid strenuous exercise up to the level of exhaustion. So a mild to moderate exercise program is fine. We usually ask them not to compete in sports. They have to do everything possible to prevent infection. So taking care of their skin, taking care of their teeth and gum is very important, and take SBE prophylaxis according to the American Heart Association guidelines. Some patients feel better taking oxygen. There is no proof that it affects outcome at all in patients with Eisenmenger syndrome, but if they feel better on it, I'm fine with it. When patients with Eisenmenger syndrome go to the hospital, we always tell them ask the nurses to put a filter on the IV line to make sure there's no air embolism that could go paradoxically into the brain or into the coronary artery. So this is very important part of a quality measure for the hospital. They are at risk for infection, so the pneumovax and flu vaccines are indicated in these patients. And it's a myth that these patients cannot travel. As long as they are traveling in a pressurized cabins, it should be okay to travel by air. However, they need to walk and keep themselves very hydrated. And with everything that we currently do in patients with Eisenmenger syndrome, or not do, because we don't want to do any harm, recent advances have showed that survival has significantly improved. 87% of Eisenmenger syndrome live for at least 20 years after diagnosis. So in conclusion, Eisenmenger syndromes are often natural survivor of unrepaired, simple, and less commonly complex congenital heart disease. They have challenging multisystem disorder where a lot of education have to happen between the provider and the patient. And important to reduce this knowledge gap, and that's one of the reasons we produce this video, to prevent complication. There are treatment options available that will improve 6-minute walk, quality of life, and oxygen saturation, and possibly survival. And with many complex diseases, a multidisciplinary team approach with expertise in this field is needed to take care of these patients who can get very, very sick. And with the care provided, specialized care provided for these patients, survival into the 60th decade is possible. Thank you for your attention. If you have any question regarding this subject, I'm providing my email address.